Hi, Lisa. Looks like we are recording, so I am going to go ahead and just make sure that everybody, I think you should have presenter capabilities and everything. So just let me know if you have any issues.
Okay. Okay. Sounds good.
That was real. Oh my god, that was even worse. That happened with
Hi, everyone. Just a quick note. We're going to still keep admitting folks, and we'll get started here in just a couple of minutes. I'm just going to give it another just a couple minutes, folks. Thanks for your patience. All right, it looks like we have been able to add most folks. So I'm going to hand it over to our administrator, Stacy Weeks, to go ahead and kick off the webinar for folks. And if I could ask Marissa to please share the slides.
All right. Thank you, Melinda. Good morning, everyone. Thank you for joining us. Today, we're going to do, I think you guys know, an actuarial meeting with interested bidders. Next slide, please. First, we're just going to do a real quick recap background on the program, and then we'll talk about the reference premium, how we're planning to calculate the savings targets, specific data requests that we need to make sure we're able to adequately define the reference premium and savings targets, next steps, and then a little bit about the timeline and questions going forward. Next slide, please. Just a reminder, the state battle-born plans are defined under Nevada Statute 695K, which requires the director of DHHS, which has been delegated to our division, DHCFP, to contract with carriers to offer public option plans, which, as you guys know, we're calling the battle-born state plans. These plans must be available as qualified health plans on the Silver State Exchange beginning plan year 2026. The law requires, among other things, establishment of a reference premium and a premium reduction that is at least 15% lower than the reference premium over 4 years. Carrier submission of a good faith bid to the public option plans. Carriers must have a submission of a good faith bid to offer a public option plan if they seek to participate in the Medicaid managed care program in the state, which, as you know, will be rebid in the coming months. And this is just right now, we are in the process of step 1 of this RFP. There will be a step 2, and it's available on Nevada ePro. Next slide, please. This is just a visual to kind of, I think, if we can step back and understand sort of how the battle-born plan kind of looks in the market as compared to other plans and how it operates similarly to other plans as well. So that middle circle there in the middle is our individual market plan today. These are plans that individuals that are purchasing coverage for themselves. They don't have employer coverage, Medicaid, Medicare. They are purchasing their own coverage in the market. They can go directly to a carrier and purchase that plan. This was the way it was before the ACA. A lot of plans can still be purchased that way today. And these plans all have to follow state network adequacy requirements in state law, solvency standards, rate review process with the Department of Insurance, and other market rules. Some are in the Affordable Care Act, but others are in our state law that they have to follow. The second tier of plans that we have in the state are our standard exchange plan. Now, they have to follow the individual plan market rules, but they have to follow an additional set of rules, as you can see that bigger circle around here. And these rules if they follow these standard exchange plan rules, they're allowed to be offered through what we call our state exchange, Nevada Health Link. And Nevada Health Link, as you guys probably know, consumers are eligible for premium tax subsidies. But these plans are what we called our qualified health plan under the federal law. They have to follow all Affordable Care Act standards. They have to meet the essential health benefits. They have certain consumer protections in place. They have to have a qualified health plan certification by the exchange, and they have to pay an issuer fee to be offered through the exchange. The battle-born state plan is a third level of requirements. So battle-born plans still have to meet that individual market plan in the middle. They still have to follow all the standard exchange plan requirements, but they have to follow an additional layer of requirements. They have to meet, for example, we're going to talk about today, the premium reduction target. They have to offer contracts to providers that are going to pay providers no less than Medicare. So it's Medicare or better. So there is a floor there, unlike the other plans in the market. And they have other contract requirements with the state, which is DHCFP, under state law that they must meet. Next slide, please.
Oh, Stacy, I just really quickly, I apologize. I just wanted to jump in really quick and mention that this meeting is being recorded. So for those on the phone, just so you know, thank you.
Oh, I'm sorry, Melinda. You messaged me. Yes, thank you, Melinda. So the 1332 waiver application was also something that's required under state law to capture any federal savings and waive any rules that are necessary to operate this program. Governor Lombardo put together, our administration put together under Governor Lombardo what we call the market stabilization program to ensure that these new plans are able to, they're not going to disrupt the market, and that we're able to ensure that we are investing back into our marketplace. Here on the left, the first thing that's going to happen when these federal savings come in is they're going to be invested into reinsurance. If our waiver is approved, we'll get the savings from this program and premium tax credits for consumers, and we'll use that to fund a reinsurance program first. It'll apply to all individual market plans, and it subsidizes the high cost claims in the market and hopefully reducing any risk of cost shifting. And then whatever money's left over in year 1 or 2 and ongoing, that we will be using those monies for quality incentive payments to any of the carriers that participate in the BBSP program. And it will be an annual bonus payment for plans that meet certain quality metrics or the providers are participating in value-based payment design. We're still working through the parameters of that and will be released in step 2. And then the third waterfall of funding would be the workforce investment. So if there's remaining funds in future years, we'll be looking at investing those in potential loan repayment programs to providers who will live and work in Nevada for at least 4 years. So you have to make that commitment to be eligible. Next slide, please. So I am going to turn this over to our folks at Milliman because this is definitely their expertise. Thank you.
Okay, great. Thank you, Stacy. My name is Fritz Bush. I'm a principal and consulting actuary with Milliman. I'm going to be going through the actuarial aspects, several of the actuarial aspects of the BBSP procurement process. That'll include the reference premium, the savings targets, and the data requests. So we'll start with the reference premium. So the reference premium was defined in the original legislation, and it's also defined in the statutes that were noted on previously on page 3, on slide 3. What you're going to see in these slides is a modification of that definition of the reference premium. Those modifications were authorized by the guidance issued by the Department of Health and Human Services on November 20th of 2023. The modifications were made to address concerns related that Stacy mentioned before, related to maintaining a stable and a competitive marketplace. So the starting point for determining the reference premium, again, according to the statute, this is unchanged, is the actual 2024 benchmark or second lowest cost silver plan in each county. Now for calculating the future year's reference premiums, there is a trend applied to this starting point projected to the plan year. That trend factor will be CPI medical because as everybody knows, CPI medical does not capture all of the elements that would be otherwise captured. Doesn't capture all the elements of healthcare inflation that would be considered in pricing. There are other adjustments that will be made to capture those market dynamics. So these can include things like utilization increases, which would not be in CPIM, morbidity changes in the market, and any other market disruptions, such as things we've seen recently, such as enhanced subsidies, Medicaid redeterminations, or really any other currently unknown future market impact would need to be in there. The intent is to solicit information from carriers through the DOI and on all of these impacts to inform the setting of the reference premium each year. Got several slides later. We'll talk about this process and those data requests here in just a minute. It is important that the reference premium be set accurately, as there are downstream impacts if it is set inconsonant with the overall market. If it's set too low, the savings targets become unrealistic, and it is not the intent of this process to drive any more or any less savings from BBSPs than are required by the statute. Conversely, overtrending creates risks in the state's justification of the federal pass-through savings attributable to BBSPs under the 1332 waiver. Those savings are very important because they fund the state's liability for its share of the reinsurance program costs. Let's go to the next slide. So once the premium is set, the premium reduction targets for the BBSP plans are set relative to that. Now we have draft targets by year on the next slide. The reference premium and the savings targets are set once a year, and the timing of those targets being published is still being determined, but it will certainly be compatible with the ACA rate setting and filing process that occurs in the first and second quarter of each year. The process for 2026 right now is a little bit different because of the procurement process that is taking place. In this case, there is a preliminary reference premium that is going to be set and savings targets set, and that is for purposes of the good faith bid that Stacy mentioned earlier. However, these will be revised in the spring with the latest information that is available and that which we will request with the help of the DOI sometime in the late first quarter or early second quarter of 2025. So a few limitations here that we should point out. The savings targets apply only to the silver plans, not to bronze or gold. It is expected that the BBSP bronze and gold plans will follow appropriate ACA rating rules, and these relationships will be reviewed as usual by the DOI. The premium targets will be achieved through both reductions in provider reimbursement and carrier administrative expenses that are loaded to BBSP plans. As such, it is expected that the lower cost structure will be reflected in BBSP rates, specifically through the network factors and the administrative load factors that carriers will have in their filing materials, including their URRTs. I'll talk a little bit more about this in a couple of slides as well. It's very important. The guidance related to the exact split between the savings attributable to provider reimbursement reductions and the administrative cost reductions will be communicated at the time the reference premium is published. We can go to the next slide. Okay, so as I mentioned before, the table on the left shows what are the expected targets at this time for the BBSP plans only. So this does not include the impact of the reinsurance. So recall that prior to the introduction of the reinsurance program, the entire 15% savings relative to the reference premium in year 4 would have had to have been achieved through provider reimbursement reductions and carrier administrative cost cuts. So the reinsurance program basically cuts the BBSP target to roughly half, savings target in half by year 4. So it's a significant contribution to hitting the savings targets, the premium targets. Also, in response to the stakeholder feedback, we're implementing what we are calling the adjusted premium targets, and I'm going to introduce this idea here, but then we'll see an example of it later in just a few slides. I think it'll become clear with some simple numbers. The purpose of the adjusted targets is to recognize and be responsive to market realities as well as being responsive to stakeholder feedback. The reality is that marketplace carriers' relative positions to the benchmark plan can vary greatly. So these, carriers with a relatively less competitive position in 2025 will find it very challenging to improve their position and meet the savings target in just a single year. So the adjusted targets are intended to take this into consideration by allowing carriers to move closer to the savings target over the first 4 years of the program with the intent that all BBSP issuers will be at the savings target by year 4, which is 15% below the reference premium, which includes the impact of reinsurance. So again, I have another illustrative example coming up in a few slides here. So let's go to the next slide. We'll talk about the reinsurance program very quickly before we get into that. So the reinsurance program starts in 2027, not 2026, because as mentioned before, the pass-through funding from the first year of the BBSP program in 2026 is needed to fund the state's obligation under a reinsurance program. The reinsurance program applies to all plans, not just BBSP plans, and the parameters that we're currently using in the waiver modeling can be seen to the left there in bullet point number 3, $60,000 attachment point with $1 million cap and 20.5% coinsurance. Those are subject to revision as we get more experience. On the right, in the table, this shows we just took this table straight from our waiver modeling, and it shows the total impact from each part of the program, the BBSP program and the reinsurance program respectively. So as you can see, again, the reinsurance is expected to achieve just under half of the premium reduction target for BBSP plans. The other half of it under the BBSP column is again attributable to provider payment reductions and administrative cost reductions. Very quick side note, not to confuse anybody, the numbers under the BBSP policy only column are slightly different than the previous slide. And that's because we took this from our waiver modeling, and the BBSP policy only column includes a slight favorable morbidity impact. So that's why they'll differ by basis points there between those two slides. Okay, we can go to the next slide. All right, so now we're going to get into the detail of setting the reference premium. So on the screen, you'll see a process that involves 14 steps that we're going to use to calculate the reference premium. Now, we constructed this example with a generic SLCS using just a single county. We used just $100. Everything here is purely illustrative. At a high level, the process is broken up into two parts. The first part is steps 1 through 5, as you can see there. That part is somewhat of an academic exercise that attempts to simply summarize the most recent market information that is captured in actual pricing. So the process starts in line 1, as was mentioned before, starts with the actual 2024 SLCS. The second line is known as well, or will be known very soon once rates are finalized, and that is what is the 2025 second lowest cost silver in the same region. Step 3 just divides those two and calculates what the actual change was, and then the CPI medical is inserted there for that particular period. And so the implied market adjustment in total for all possible impacts that we mentioned before, things like utilization, morbidity, et cetera, the implied impact is the balancing item between those two, which is 1.4%. Now, again, this step is entirely retrospective, and it's premised on the idea that the best possible information about the market as of 2025 is already captured in carriers' pricing, in market pricing. The second part, however, is prospective. And to do the projection, we will have to gather or solicit the best possible market information from carriers. And we will use that information confidentially and in aggregate to prospectively set the reference premium in each county. So looking at line 6 now, we start the projection as described before with the CPIM factor for a specific period, which we will need to provide detail on how that CPI medical factor will be chosen, and we will do that in future guidance. From there, the additional factors that would go into the actual pricing processes are listed. So it is expected that the multiplicative sum of these factors, so the CPI factor and all of the other market-based adjustments there, would equal line 13, the total expected rate change by county or region. So lines 6 through 12 then essentially become explanatory in nature. However, they are valuable to us because we may need to use that information to make other adjustments. So again, the data collection process we're engaging in with the DOI is intended to form the basis of these calculations in the second part, the prospective part. And we designed this process to be as simple as possible and as transparent as possible. However, it is a new process, so we're certainly open to any suggestions on how to improve it. We can go to the next slide. All right, so now we're going to turn to the savings targets in a little bit more detail. So as we mentioned before, the savings targets are more complicated, but the complication is not without a purpose. The purpose, as I said, is to be responsive to stakeholder feedback and to recognize market realities with the goal of not destabilizing the market, but rather improving its stability and its competitiveness. So on the slide, you can see an illustration, again, using just a generic $100 benchmark, silver plan rates. And the competitive situation is summarized in the next column to the right, the third column or second column from the left. So as you can see, there's a full 35% difference between the SLCS and the least competitive plan in the county. So if carrier G was interested in becoming an MCO and offering BBSP plans, it would be very challenging for them to meet the savings target in year one. You can also see on the right-hand column there, we've assigned them a tier 1, 2, and 3. And we explain that below in the second table on the slide there. The phase-in schedule, which is shown in that table, is based on carriers 2025 positioning. They will be placed in a tier, and that tier will basically dictate a percentage of the difference between their current rate position and the benchmark plan that they will have to achieve in the first year. So as an example, in 2026, the tier 3 carriers, instead of, excuse me, okay, I'm on the bottom table now. As an example, in 2026, the tier 3 carriers, instead of having to adjust rates to entirely meet the target in a single year, will only have to adjust their rates to cover half of that distance. Notice that tier 1 carriers will have to meet the unadjusted target, and we will set up the process so that regardless of competitive position, there will always be at least 2 carriers in tier 1. So a numerical example, I think, at this point would make this clear. So why don't we go to the next slide? All right, so if you focus first on the table, not the words at this point, and specifically look at the 2026 column. And again, using carrier G as the example, without any type of an adjustment, this carrier would have to reduce rates to meet the savings target by an estimated 28%, which is very challenging. You can see the other carriers, of course, all have different amounts that they would have to adjust their rates based on their 2025 position to meet the savings target. Also notice that the dynamic on the right, that in the years 2027 through 2029, the rate reductions needed to match this premium target are very similar between carriers, and that's because everybody has made the adjustments in their rates in year one. Again, this is without any type of an adjustment to this schedule. Now, if we go to the next slide, you can see what that then looks like, and that'll help you interpret these numbers. You can go to the next slide. There we go. Okay. So here you can see that carrier G now, their target will be such that they will only have to reduce their rate by 14%, which is exactly half of what their previous projected adjustment would be. And so that's what the 50% means on the phase-in table 2 slides ago. You can see the tier 1 carriers, they have to meet 100% of the premium target, but of course it should be much easier for them because they're already relatively close. Also notice that the dynamic in the out years changes, because now instead of adjusting rates all in year 1 to meet the savings target, you've deferred some of that work, for lack of a better word, and there's additional savings that now need to be achieved in years 27, 28, and 29, such that all carriers meet the unadjusted savings target of 15% below the reference premium by the 4th year. Okay, we can go to the next slide. Okay, so we'll talk quickly here about the data requests. So again, to review, the purpose of the data requests is to ensure that the reference premium is the best possible estimate, commensurate with the overall market and the benchmark plan in the absence of the waiver. So our process, again, to review, assumes that the best possible information on the market is contained in the most recent year's pricing. So in this case would be 2025. The information for the prospective piece of the process needs to come from the data request from carriers. Like the reference premium, we've tried to keep the data request simple and transparent, but it's a new process. So again, we are open to suggestions on how to improve that, either the process or the forms. For the current process of setting the preliminary reference premiums and savings targets, we'll be relying on the finalized 2025 rate information when that comes out. And in addition, we'll be relying on some of the information collected from the DOI through the forms that were sent out to carriers. And we'll go through that in a little bit more detail now. So we can go to the next slide. Okay. If you're an actuary on the call, you probably recognize this form. It was sent out maybe a week or so ago. And if you're a pricing actuary on the phone, you'll recognize that this is just a simple way of capturing the basic pricing process of revising estimates and adding on the additional projection factors needed to move to the new rating period. So in question 1, we're just asking for that estimate of future trend. In this case, it would be 25 to 26. We have a unit cost and utilization. We will probably modify this to note that it is a combined medical and RX trend. Question 2 asks for any restatements. So this could be restatements of previously year 2 trend in the 2025 rates. It could be a restatement of your base period, but just basically revised estimates, that would roll into 2026 pricing. And then question 3 is the prospective piece again. So just asking for information on any other prospective adjustments. We talked about those before, things that might come up due to enhanced subsidies or any other, unknown market impacts right now. So these questions are set up to correlate pretty closely with the second half of the reference premium section that I noted before. Now, I want to make one quick note about this because this might be occurring in people's heads. So we understand that the 2025 pricing process is basically just getting ready to conclude here. And as we've said a couple times before, your best estimates are almost certainly baked into the current pricing, and you don't really have any additional revised estimates for, say, question number 2 at this point. Not only that, but your estimate for question number 3, they could be half-baked at best at this point. Okay, so we understand that. However, this will not be the case in the spring. This same form will be used in the spring, and we will gather a second round of information that will be used to set the final reference premium in the spring. So for this round, we're just simply asking you for your best information possible, which could be precisely what you put in your filing. So we understand that. Let's go to the next slide. Uh-oh. There we go. Is that it? Yeah, that's it. I'll go through this pretty quickly. Really not a lot to say here. We will be using edge files to set the reinsurance parameters. We've got a little bit of time on that, obviously, since 2027 is the beginning of the reinsurance program. We will be using that to update the parameters that we showed you earlier for the latest possible experience. We'll be using that for various purposes, specifically around pass-through funding and doing financial projections as well. There will be a process to apply for pass-through funding and to justify that pass-through funding. Of note here for carriers, I said I would emphasize this again, and this is that slide, is that there is an expectation that the reduced cost structure for the BBSP plans will be reflected in the network factor differentials, assuming that the price meeting the price target will involve some type of provider reimbursement reductions. It will also be reflected in lower administrative factors relative to standard QHPs, again, reflecting the lower cost structure that's required for BBSPs. Next slide. All right, so next steps, carriers can submit feedback on the data request template to the DOI by the end of the day today. The DOI will notify carriers if there are any modifications to the template by the 19th. We request that the data be back to the DOI by the 26th, because that information will then be used in the procurement process in the setting of the preliminary reference premium for the good faith bid process. And then the step 2 of the RFP will be released in early September. Next slide. And there is some additional information on the contact information and timing on questions. So at this point, I believe I'm turning it back to Melinda.
Thanks, Fritz. Yes, thank you. So if you would like to ask questions about the information being presented today, I would ask that you please use the raise hand feature on the Teams platform, and I can unmute you. If you're calling in, please press *5 to raise your hand. Okay, we have a question from D. Clamp. D, please go ahead.
First of all, thanks for having the meeting and letting us see some of this detail and how it all connects. I do have a couple questions about how the data ask connects to those items that would be, I guess, for lack of a better term, moving trend above a CPI level. And so I guess my question is, the CPI level is a number around 3 to 4%, like in Fritz's illustration. Our pricing trends are typically significantly higher than that, as it includes items, as Fritz alluded to, that aren't included in CPI. The data request simply asks for what our trend is, but then also asks for some items down below, things that you foresee taking place. That Fritz, I think, linked that to the things that are above CPI. But I guess to me, a lot of those things that would be above CPI would already be subsumed in our higher trend number that we submitted. So I'm struggling a little bit with how the data request that kind of starts with our pricing trends and then asks for additional information connects to a trend build up from CPI with that additional information.
Can I just jump in? Could you please introduce yourself and which organization you're with?
Sure. D. Clamp, and I apologize. Maybe my familiarity with Fritz made me not feel like I had to introduce myself. I'm with Elevance Health, and
okay, thank you.
And representing the Elevance.
Okay, Fritz, do you want to try to allude how we're going to look for increases on top of the CPIM, or explain?
Yeah, I get your question, D. I think right now the data request, you're right, has sort of an aggregate trend, and I think is your main concern, are you starting with the data request in terms of understanding this problem, or are you starting with more with the development of the reference premium?
I'm just trying to figure out how they connect, Fritz, because the data request, it feels like you're saying give us your trend, and then down below give us a whole bunch of other headwinds or changes, drivers, things, headwinds or tailwinds. But whenever you build it up, you're starting with CPI and then putting in those headwinds, tailwinds. So it seems like there's a disconnect between the base you're going to start with as we provide headwinds, tailwinds, and the base we're starting with.
Yeah. Well, we want those to be consistent. I think one of the way that the reference premium is set up, the development of the reference premium, it reflects the sort of the regulatory requirements around using the index, the CPI index, and then being able to identify, well, what went in on top of that. I think in the end, what we're saying is that your pricing trend is the best information on the pricing process, obviously, and there will be a delta between those, but we're just seeking to understand what the delta is in the reference premium so that we can be very explicit about what were those market adjustments. So I think if I answered your question, I think what I would summarize it as saying, your pricing trends and the rate increases that you come out, again, we assume that that is the best information about the market. However, we do have a regulatory explanatory type of construct that we need to put together as we develop the reference premium. It's expected that those can be reconciled and that any delta above CPIM is basically reconcilable to your medical trend or to your rating trend.
Yeah, I mean, it's challenging, I guess, whenever we don't know what utilization and so forth is in CPI medical, and what's baked in their cake versus what's baked into ours. I mean, obviously we know everything's baked into ours. So, but anyway, that helps me at least formulate some way of responding to some of this. The other thing that I've got, is there any opportunity, because the data request questions are due at the end of today, but this session was only today. So it seems like this gave us a lot more information than we had with just a written data request for us to digest and see if there are other questions. Is there any way to get an extension? I guess I feel this not only on the data request, but the whole thing feels really, really compressed, like you kind of mentioned. But what are the thoughts on that?
I think that.
Go ahead, Fritz. I mean, I'll just be honest, we're doing the best we can. So,
Understand.
Go ahead, Fritz.
Well, I think the actual data is not due to till the 26th.
Exactly.
Yeah, but if there's any now the carrier template went out from the DOI, I think a week ago, or maybe a little over a week ago. I'm not sure at this point.
Fritz, if I could just jump in, yeah, we sent it out
Yep.
August 1st, and it does say in the email it's due August 26th.
Okay, does that help, Dee?
I mean, I understand the dates, and we'll do our best to comply. I guess on some levels, this meeting plants a lot of potential understanding that we didn't have beforehand that could lead to questions. And so it seems like everything is really, really compressed. But anyway.
So Dee, this is Stacy Weeks. It is a reality we're working under, and this is the best we can do. So as you can see, you can submit additional questions by Friday, 8/16, and we will respond to them on publicly August 20th before you have to do a letter of interest. So this is not just it is just a letter of interest that we're asking for step 1.
Okay, very good.
Okay, we do have some more hands raised. So next on the list, we have Mark Faber. So Mark, if you could please introduce yourself and your organization before you ask your question. Thanks.
Good afternoon, Mark Faber here. I am with CareSource and the Senior Director of our Product Development area. I was interested to know for potential new participants in plan year 2026 to the QHP market, how will they be considered within the tiering and adjusted premium reduction targets?
Yes, thank you for that question. I was remiss in putting that in there. They will be considered a tier 1.
All right, thank you. And it looks like we have another hand raised. So next we have Julie Cooper. Julie, you should be unmuted.
Hi, this is Julie Cooper from Select Health. Can you hear me?
Yep.
Yes, we can.
Okay. The first question I have is, what are you doing to account for the richness of the benefit of the Battle-Born States standardized plan, silver plan, compared to the lowest cost silver plan offered in the market? Because just because 2 plans have the same actuarial value, there is a significant difference in pricing AVs for silver plans even within a carrier. So if you're just picking the cheapest silver plan in the market, what are you doing to adjust the cost of the benefits up so that it's relative and apples to apples to the new benefit plan that will have to be offered?
So Fritz, I don't know if you want to take that,
Uh,
but we're not asking for any new benefits in this plan. So I just want to be clear on that.
Yeah,
Fritz?
there's no standard plan that's being defined. There's no adjustment though for actuarial value for plans, because that's not how the marketplace works. So if we started making adjustments between benefit plans from one year to the next, say from the 2024 plan to the 25, and then from 25 to 26, the marketplace, of course, and subsidies are agnostic to whatever benefit level it is. So it's just the second lowest cost silver by price. So we really couldn't do that in here. We need the battle-born state plans to be the second lowest cost silver, and the lowest cost silver preferably, regardless of the benefits, because that is what will determine the pass-through funding.
Right, I understand that, but in your target, your 2026 target, it should be accounting in the benefit difference between the current lowest cost silver and that benefit design that you're requiring to be offered as a battle-born state plan.
I don't know that I have any more to add to my previous answer. We aren't requiring, there is no requirement for a standard plan under the battle-born state plans. And we can't take into account actuarial value of plans, because any adjustment like that would jeopardize the pass-through funding. So it just has to be based on pure price.
Okay,
I
thank
would
you.
I would just note too that again, we are not adding new benefits. We're not doing, it's just like any other QHP that you would put on the market. You just have to meet a target.
So, okay, so thank you. My next question is, I believe you referenced that you'd have a different administrative load for the battle-born state plans as compared to your other QHP plans. Is that correct?
Correct.
So in a single risk pool model, the URRT has one entry for administrative cost. It doesn't allow for a different administrative load for certain plans versus other plans. So I'm not certain how you intend to do that, or
So could you please submit that question? That's not relevant to the slides today. So if you could submit that question through the email, we will follow up with you on that.
okay, thank you. That's all.
Okay, I do not see any other hands raised. So again, if you have further questions, please use the raise hand feature in
I just saw
Teams,
one.
or if
It
you're
looks like
calling
there's
in,
two more.
please press *5 to raise your hand if you're calling in. All right, so we have Rob Bowman, and you should be able to go ahead and speak, Rob.
Rob, we can't hear you. I don't know if you're on mute or if you realize you're on mute.
I was the vaunted double muted.
Okay.
Yeah, good morning, Rob Boffman, Plan President, Molina Healthcare, Nevada. I've actually got a couple of questions here. Please let me know if it'd be more appropriate to submit in writing versus here verbally. But the first question is relative to the various hearings that we've got. On that, will the tiering be done by region? I know there's a lot of talk on county, Fritz. Are we looking at doing things truly by county or by the region that the current marketplace offerings look at?
That is a good question. It's a good question. We had thought about region, but now your question is making me reconsider that. Why don't we take that one back, and we'll respond to that in writing.
Okay. Yeah.
Yeah.
Okay. Thank you, sir. And then the next element of that is so with carriers that are part of the graduated premium reduction, so the tiers 2 and tiers 3, will that reduction target the reductions between the administrative and the network savings in combination with reinsurance? Will that distribution be differentiated as well? given those hearings?
Yes. If I understand your question, you're saying if you have a graduated premium target, is the division between the provider and the provider reimbursement reductions and the administrative cost reductions, is that going to be graduated as well? Is that correct?
Right. Correct. Yeah. So for example, if you're assuming that, in total to get to the 15% eventually, it's at the 7%. And I can't remember what the tiering was for like a year 1 or 2 or 3, but essentially during those years, are we assuming that the full benefit of the reinsurance would come and that the savings to get to the tiered target would come from the administrative and network savings, or would that just be across the board? You'd have a reduced reinsurance benefit as well.
I am going to defer that one to a written answer. Let us think about that one. That's a very good question too.
No worries. And then the last one is, so given that the RFP and what we're going to be some level of attestation from us in terms of our ability to do this out into the future. A big part of that actuarial soundness is the approval of the 1332 waiver with the benefit of the reinsurance. Can we assume that the implementation of all this would be contingent upon the approval of the 1332, or is that something that the attestation can be slightly amended to say that, hey, we can get to these numbers with the approval of the 1332? Has there been any thought on that?
Stacy, can maybe you or Melinda take that one?
Can you reframe that? Can you repeat that question, Rob? Sorry.
Yeah, no, absolutely. No worries. So right now we're going to attest to, hey, we can do this and we can do this and reach this in 4 years. And a big part of the assumption on being able to do this is the reinsurance, and the reinsurance is subject to the CMS approval of the 1332 waiver.
Mm-hmm.
The attestation right now just says, hey, we're going to be able to do this. It doesn't mention that it's kind of contingent upon that reinsurance happening and the 1332 waiver being approved.
We mentioned in there that everything is contingent. We have to follow state law. At this time, we're all going to assume that it's approved. If not, it says in that RFP that we'd be adjusting accordingly. So again, it's just a letter of interest. It does not, step 2 is you'd have to complete the entire bid process to get a contract. So I just want to be clear on that. And if you want Rob to also send that in writing, and we'll make sure that's a written response as well.
Perfect. Thank you so much, gang. Appreciate it.
Thanks, Rob.
Great, thanks. All right, so next in the queue, we have Douglas Saunders. I'm going to allow your mic, so might be double muted, so please feel free to unmute.
Can you hear me?
Yes, thank you.
Yep. Thank you. Doug Saunders with Elevance Health. I also had a 1332 waiver question, and thank you for this presentation. It's really helpful. So I think the waiver was paused by review of CMS March 21, if I remember right. How does anything here with the data request you're asking for, does that factor into what you're working on or what may be updated in the 1332 waiver? Can you help us think through that? And then is there any insight you can provide about when you expect the waiver review to resume?
So to be mindful of the rules of this process, we're trying to answer questions that relate to the slides. I know the 1332 waiver is in there, but if you could submit that in writing, we'll have a response to you next week on that.
Oh, okay. I thought it was because this data
I can't
request.
provide any update beyond that today, but I will if you submit it in a question. By then I will have an answer.
Okay, thank you.
Great. All right, and next we have Mark Faber. So please go ahead, Mark.
Hi, Mark Faber again here. I put a question in the chat, and I wanted to just make sure that was seen as well as expand that a little bit. The reference to the standard silver level QHP, wanted to confirm if that's required to align to the federal standard silver plan design, as well as if there's going to be any requirements around non-standard plan limitations or making standard other standard plans available at different meta levels that align with sort of the federal requirements that exist.
Yes. So
I've-
the use of now I see where maybe this previous question was coming from. The word standard here does not mean a standardized plan. The word standard here just means a non-BBSP plan, just a normal standard. Well, see there, I used the word again, but just a non-BBSP plan. So it is expected that carriers would continue to offer their normal plans, not necessarily just all BBSP plans. So that's what standard refers to there, not a standardized plan.
Thank you for that clarity. And then as far as any of the non-standard plan limitations, is there any anticipation that that'll occur in the state?
So you just have to meet all the qualified health plan rules and be certified as a QHP. That's all you need to do and meet the target.
Thank you.
Okay, I'm not seeing any other hands raised, so just want to pause. If anybody has any further questions, please feel free to raise your hand. Okay, I'm seeing none further.
Okay, thanks, Melinda. And just want to encourage everyone to send in questions that you need more clarification on that maybe didn't really fall under today's presentation. If you can get them to us by Friday, we're going to work really hard to get them back out Tuesday as much as we can. So please, think about the ones that you want more answers on, and hopefully by Tuesday we can get everything out the door so you guys have that information before the letter of interest. Homa, I see your hands up. Go ahead.
Thank you. I just wanted to, I'm General Counsel for State Purchasing, and I just wanted to clarify when healthcare financing and policy is saying we, kind of the royal we, make sure you're adhering to, if you're calling in by phone, there's a slide indicating how that contact needs to take place, because we really want to make sure that nobody accidentally disqualifies themselves from the RFP process by not going through the single point of contact. So the single point of contact as listed on the slide is Ryan Bradenberg with State Purchasing. Anything you have, even if you think it's a silly question, route it through purchasing. We will make sure it gets to the right people, that there's transparency on the answers so that everyone can see the answers. So I did just recognize that you're hearing this we, as in we, the state. Please make sure you're using the single point of contact, because we want to make sure the integrity of the process is protected.
Thank you, Homa.
Thanks, Homa. I do have one other hand that was raised from Jessica Bell. So Jessica, you might be double muted, but please go ahead.
Jessica Bell with Elevance Health. Thank you for this presentation today. So when we send our questions into Ryan, and I see his email on the slide, will the questions and the responses, will those become public, or those will remain between the person who asked the question and Ryan?
So this is Homa again. Those are public. So what will happen is it gets posted to the Q&A on Nevada ePro. So if you had a question that you wanted to be private, it couldn't be made private. It would be public, and the answer would be public. And also you can identify who asked the question through Nevada ePro.
Okay, thank you so much.
Okay, not seeing any further hands.
Let's give it a minute. I know some people can be shy. Just make sure. If you have any other questions, or Fritz, if there's anything you think we need to clarify from questions in the slides, just one last second.
And while people are formulating that, this is Homa again. It was mentioned in the chat, there was a question about the informational deck and the recording being shared with attendees. That'll be posted to Nevada ePro. I put the link in the chat, but you can also go to nevadaepro.com and just put S2910 in the search box, and it'll pop up with the listing. And Nevada ePro is at its best, actually, when you don't log in, as far as being able to see certain information. But obviously, please do register as a vendor if you're not already registered, and then you'll be able to, go through different submission processes as the different phases of the request for proposal moves forward.
And I just want to be clear on the letter of interest, because I feel like there's a lot of angst here today about that. It just so you can qualify for step 2, which, as we clarified, is around the good faith bid. So if you want to be considered for that, step one is it keeps you in the process, and then step two is the rest of the RFP process. This is just to get you into that door. Okay. Any other questions that folks want to raise? All righty. I don't see any other hands. All right. Well, thank you all for your time. We will, as you know, these slides will be available through purchasing. Please send in your questions and we will work on them over the weekend and try to get them out as soon as we can on Tuesday. But very much appreciate your participation and interest in the program. And we look forward to hopefully seeing folks' bids. So thank you very much for your time. Have a good day.